this podcast, we're going to talk about the thyroid and parathyroid glands. Now, the thyroid gland is located in the anterior neck region. It's adjacent to the larynx and the trachea. It's a bilobed organ, as shown in the diagram, and the lobes are connected by an isthmus. Now, there's a thin connective tissue capsule that sends trabecula into the parenchyma, and those kind of partially outlined lobes. Those are not always so evident on histological sections, but what is evident are the distinct thyroid follicles. So the thyroid gland is a very easy organ to identify histologically. The parathyroid gland generally consists of two small pairs of endocrine glands that are associated with the thyroid. They're in the connective tissue capsule on the posterior and lateral surfaces of the thyroid, and so here you can see the thyroid gland and the parathyroid gland. Now, there are often anatomic variants as far as the parathyroid gland is concerned. The thyroid gland develops from the endodermal lining on the floor of the primitive pharynx. So the thyroglossal duct or midline diverticulum gives rise to follicular cells, the so-called principal cells. And as we'll learn, these follicular cells are the cells that secrete thyroid hormones. And the ultimobranchial body from the fourth brachial pouch gives rise to the parafollicular or C cells. And as you'll come to appreciate, the C cells secrete calcitonin. The parathyroid gland develops from the endodermal lining that's derived from the third and fourth brachial pouches. The inferior parathyroid and the thymus come from the third pouch. The superior parathyroid comes from the fourth pouch. Let me go to the next slide and then I'll come back to this image. I don't expect you to remember this in great detail for our course, but it's just showing where the development of these organs come from. So the thyroid gland like this, the parathyroid glands from the pharyngeal pouches, here the ultimobrachial body giving rise to the C cells of the thyroid gland, here the thymus. Now let me go back to this slide because here is actually a slide from a human infant and it's showing three organs: the thyroid, the parathyroid, and the thymus. And it's easy to distinguish each of these organs histologically. You know from your gross anatomical relationships that they're in the mediastinum area, and that's evident on many histological views. The thyroid follicles shown here, this is the structural and functional unit of the thyroid gland. The follicles are basically cyst-like compartments that have a wall of simple cuboidal or low columnar epithelium. These cells are the so-called follicular cells. They're also called principal cells or sometimes A cells for acinar cells. The follicular cells secrete thyroglobulin, and thyroglobulin is inactive thyroid hormone, and thyroglobulin is stored extracellularly in the colloid. The parafollicular cells, so-called C cells, are not in contact with the colloid, but they lie within the basal lamina of the follicle. And in the image on the right, you can see the parafollicular cells labeled and the follicular cells labeled. These would be parafollicular cells on this micrograph. So parafollicular cells, parafollicular cells. Parafollicular cells secrete calcitonin. Now the arrows on this micrograph are clearly showing some blood capillaries. As you would expect, all endocrine organs have a rich supply of capillaries. The follicular cells are in contact with the colloid. So here showing colloid, here are the follicular cells. These follicular cells secrete and or they reabsorb colloid as the need arises. In this micrograph, you can see numerous lysosomes and you can see some reabsorption droplets, and we'll talk about these later. These are labeled as colloid reabsorption droplets. The parafollicular cells, here's an example of a parafollicular cell in this micrograph. We show numerous electron-dense granules and a prominent Golgi apparatus. The thyroid gland produces 3 hormones. All of these hormones are essential for growth and development. So the thyroid gland produces T4, so-called thyroxine, tetraiodothyronine, also secretes T3, triiodothyronine, and calcitonin. As we said, T4 and T3 are synthesized and secreted by the follicular cells. T4 and T3 regulate cell and tissue basal metabolism. These hormones regulate heat production. They can influence the nervous system development in the fetus and in infants. These hormones increase carbohydrate absorption in the GI system. Secretion is regulated by thyroid stimulating hormone from the anterior pituitary. It turns out that much more T4 is secreted. Approximately 40% of the T4 that's secreted is converted to T3. T3 is the more active form of the thyroid hormones. Calcitonin is synthesized by parafollicular cells. Calcitonin is a physiologic antagonist to parathyroid hormone. Calcitonin lowers blood calcium by suppressing resorptive activity of osteoclasts. Calcitonin stimulates the rate of osteoid calcification in bone tissue. High plasma calcium stimulates secretion of calcitonin. Interestingly, calcitonin secretion is not affected by the hypothalamus and the pituitary. It is primarily influenced by high plasma calcium levels. Synthesis of T4 and T3 occur in fairly discrete steps. This is a complicated process, but it is an important process, and it is one that I think you should know about. So I'm going to take a few minutes to go over it here. The first thing we can say is thyroglobulin precursor is synthesized in the rough ER. It's glycosylated in the ER and Golgi. It's packaged into vesicles, and it's secreted by exocytosis into the lumen of the follicle. That's shown here by the events labeled at 1, and this is something you know in great detail. We've talked about the cell biology of secretion and exocytosis in other areas in the course, so I don't need to go over that again here. The follicular cells also actively transport iodide from the blood into their cytoplasm using a sodium iodide transporter. And iodide ions rapidly diffuse towards the apical membrane of the follicular cells, where they're transported into the lumen of the follicle and immediately oxidized to iodine by a thyroid peroxidase enzyme. So those steps are shown here labeled as number 2. Now, it turns out that 1 or 2 iodine atoms are added to tyrosine residues on thyroglobulin to form monoiodotyrosine or diiodotyrosine, and those are shown labeled in step 3. Oxidative coupling forms T3 or T4, which are linked to thyroglobulin, and that's what's stored in the colloid as the inactive thyroid hormones. That's shown labeled in step 4. Now, under the influence of thyroid stimulating hormone, the follicular cells are going to take up thyroglobulin from the colloid by receptor-mediated endocytosis. And I don't need to go over those details. Again, we've talked about receptor-mediated endocytosis in other areas in the course. But let's talk about this in relation to the thyroid, because there are 2 pathways for thyroid hormone utilization. There's the lysosomal pathway, where thyroglobulin is internalized and transported to early endosomes. In these These early endosomes are the so-called colloidal reabsorption droplets that I showed you in an earlier electron micrograph. These are eventually degraded by lysosomes, so you're going to form free T4, free T3, diiodotyrosine, and monoiodotyrosine. That's shown here in the label as 5L for 5 lysosomal pathway. This is the major physiologic pathway for utilization of thyroid hormone. There is a transepithelial pathway for utilization of thyroid hormone. Here, thyroglobulin is transported intact from the apical to the basolateral surface of follicular cells by a specific receptor. I don't care that you remember the name of this receptor, Magellan, but it's a receptor-mediated endocytosis. The intact hormone is packaged in a vesicle and transported with the receptor to the basal surface, where it is then released. It's interesting, this thyroid Magellan receptor, you don't have to know this, but it is very much related to the LDL receptor, which we've talked about earlier in the course. This pathway is labeled by 5 transepithelial. This pathway seems to be more prominent in certain pathological conditions where there may be upsets of the receptor-mediated endocytosis for the lysosomal pathway, and hence this pathway would then become more prominent. Now, the majority of T4 and T3 is released from the lysosomal pathway in a ratio of about 20:1 T4 to T3, and that's shown labeled in 6 on the diagram. Only the follicular cells produce T4. As we said, T3 is the more active form of the thyroid hormone, and it's produced by conversion of T4 to T3 by the follicular cells, but it's also produced by conversion of T4 to T3 in cells in the kidney and in the liver and in the heart. And that might not be surprising because all of those cells have high metabolic demands. The top part of this cartoon just highlights some of the chemistry of iodination. I don't expect that you have to know the details for our course. And the bottom part of the diagram just shows the structure of thyroid hormones. Again, you don't have to know that in detail for our course, but here showing T3 with 3 iodide groups attached, and here showing T4 with 4 groups attached. Let me say a little bit about the follicular morphology in the thyroid gland. When the follicular cells are flat, the gland tends to be a little less active, so you can see that here. When the follicular cells are a more high cuboidal nature, the gland is more active. And you can just get a little bit of a hint here in this active gland. You can see some little vacuoles. This is suggesting that there's endocytosis of the inactive thyroid hormone, thyroglobulin, from the colloid. Now let me just say a little bit about abnormal thyroid function. We talk about goiter. Goiter can be an enlarged thyroid that results from hypothyroidism. It can be caused by insufficient dietary iodide, can be caused by an autoimmune disorder. Hashimoto's thyroiditis is a very common example of an autoimmune disorder for thyroid function. What you can get is follicular cell apoptosis. You get low levels of circulating thyroid hormone, will stimulate TSH release from the anterior pituitary. That will lead to hypertrophy of the thyroid gland. You can also have goiter, enlarged thyroid from hyperthyroidism. Here you have excessive thyroid hormone released. You get increased metabolism and sympathetic nerve activity. So from hyperthyroidism, you may have weight loss, excessive sweating, tachycardia, nervousness. Sometimes you'll see protrusion of the eyeballs and actually retraction of the eyelids. Hypothyroidism can be significant conditions if not treated. This is an example of a person with hypothyroidism. Look at the bulging area in the neck. Look at her bulging eyeballs. Look at the histology of the thyroid. Here you can actually see the follicular cells. They're almost a columnar shape here, very active. Look at the extreme endocytosis. You're bringing in lots of the thyroglobulin and releasing lots of active thyroid hormone. There are two cells of interest in the parathyroid glands. There are the chief cells or principal cells. They're shown here. These are small. They have a high nuclear to cytoplasmic ratio. The principal cells secrete parathyroid hormone. As you know, parathyroid hormone increases blood calcium level. There are also cells called oxyphil cells. These are large eosinophilic staining cells. The function of oxyphil cells is not known. Here, typical histological view, you can see the chief cells and the oxyphil cells. Although we don't know the function of the oxyphil cells, these large eosinophilic cells make a nice histological marker to identify the parathyroid gland. Parathyroid hormone regulates calcium and phosphate levels in the blood. Parathyroid hormone is an 84 amino acid polypeptide. Parathyroid hormone binds to parathyroid hormone receptors on target cells, will interact with a G protein coupled receptor to stimulate second messages. Secretion of parathyroid hormone is regulated by blood calcium levels by a simple feedback mechanism. Parathyroid hormone will cause blood calcium levels to increase, and it will cause blood phosphate levels to decrease. Some of the actions of parathyroid hormone stimulates osteoblast signaling induced differentiation of osteoclasts. Parathyroid hormone stimulates calcium reabsorption by the kidney, stimulates phosphate excretion by the kidney. Parathyroid hormone also stimulates the production of dihydroxycholecalciferol by cells in the proximal convoluted tubule of the kidney. This dihydroxycholecalciferol is important in calcium balance in the body. Parathyroid hormone also stimulates calcium absorption in the GI tract. This is just an overview for you to review the mechanisms of parathyroid hormone action in relation to blood calcium levels, again, to help you integrate with what you're learning in physiology. So if there's a low level of blood calcium, that's going to cause release of parathyroid hormone. That will cause efflux. Parathyroid hormone release will cause efflux of calcium from the bone. It will cause decreased loss of calcium from the urine, and the kidney will produce a vitamin D analog, which will cause enhanced absorption of calcium from the intestine. So all of that will lead to an increase in calcium concentration in the blood.